Yes, we are.
Yes,
I am.
Five.
All right, we're about to go live.
I love seeing the number of attendees just increase one by one.
How do you see that?
I think you can see it by clicking on participants, I think, or we can see it. I'm not sure if you can.
Yeah, we can.
Kevin, let me know when I should go ahead and start. Welcome, Gladys.
I think you're good right now. We're live on both platforms.
Okay, wonderful. All right. Well, first of all, thank you all for joining us. I think this is the first webinar that the Legatum Center does, and we're very excited that that first topic is focused on reimagining healthcare systems during and post-COVID. For those of you attending and don't know the Legatum Center, the MIT Legatum Center for Entrepreneurship and for Development and Entrepreneurship was established over 12 years ago with the purpose of promoting entrepreneurship and innovation, specifically in emerging markets, as a pathway to more sustainable and inclusive development. The purpose of this webinar in specific is to really think about how healthcare systems and well-being in a post-COVID-19 world and what that might look like and what actions we should really be taking now to see long-lasting systems change. The questions that we want to tackle in today's webinar are, what are some of the innovations taking place in emerging markets and also outside of emerging markets right now? And are these innovations really first steps to long-lasting systemic change? Or do we really need to be thinking about transformation differently? And I'm really excited. We have an amazing lineup of speakers today, including both physicians and entrepreneurs covering varying geographies around the world. Very quickly, that we're joined by Dr. Samir Khleif, who's a biomedical scholar and professor from Georgetown University Medical School. We have Deb Gordon, author of the Healthcare Consumers Manifesto and a dear friend. Dr. Teddy Totimeh, pediatric neurosurgeon from Accra, Ghana. We have Dr. Rafik Bedar, who's from St. George's University Hospital in London, who is a critical care physician who's been in the front line from the very beginning. We have Dr. Amr El Tayeb from Egypt, who's a neurosurgeon and founder of Smart Medical Services. We have Dr. Gladys Kalema, I'm going to say this wrong, Zikusoka, founder and CEO of Conservation Through Public Health, and Javier Lozano, who's a Legatum Fellow and founder of Clínicas del Azúcar in Mexico. And last but not least, we have Dr. Anatole Menon-Johansson, Legatum Fellow and founder of SXT Health. So I'd love to immediately get started. Just a few logistical things. For those attending the webinar, please do include and write your questions in the Q&A box. And towards the end of the discussion, we'll be choosing questions from all of you to ask the panelists. So hopping right to it, Samir, I would love to start with you. You're a physician and you're an expert in immunology and oncology. You've also devoted a lot of time to understanding how to deliver quality care to patients, specifically in remote areas of the world. And you're currently here in the US out of Georgetown. I would love for you to give the audience what you see as the reality of how this pandemic is impacting healthcare systems in emerging markets, and also even what you're seeing here in the US. And what role do you think innovation and entrepreneurship have to play in transforming those systems?
So a couple of things. One is probably I should start from the US because in the US, as everybody knows, particularly in specific areas of the country, COVID has been a tremendous drain on the healthcare system. The good news is that it uncovered lots of shortcomings and lots of holes within the healthcare system that would generate a lot of potential. So it would generate a lot of potential innovation in the future to cover those holes, one, and second, make it not only better prepared for something like COVID, but for other issues. Switch to developing world or the emerging market. I think emerging markets have been lucky, and I've worked with a couple of countries on the containment plans, but I think it's been pretty lucky in having much less impact or increase in the spread, which is completely different than what happened in the developed world. Now, having said that, it could be only a matter of lag, or it could be because of the 6 or 7 other potential possibilities that we're thinking of, that why in some emerging markets, the spread has not been as drastic or dramatic. And that could be purely perspective, and I think that it could happen in the future, is if you look at comparing anything to the US, by the end of March, US has 160,000 cases, although the whole thing started at the end of January as a first case registered. If you look at some of the emerging markets like India or Kenya or Nigeria or Ghana or other countries, it started a little bit late. Some in mid-March. It could be also registry issues or detect an issue, but some in end of March had almost 1,000 cases. Those 1,000 cases became in some countries like India 37,000 cases in 4 weeks, although in other countries like Argentina it came only 4,000 cases, and in a country like Mexico it became 20,000 cases. So there could be an increase in the curve very soon. What that would do is, particularly in the shortages that currently existing in some of those countries, like ICU beds, we talk in the US about 38, 39 bed per 100,000. In countries like Bangladesh is like 0.5 beds per 100,000. So it's going to be, if that happens, it's going to be a major drain on the system. So going further from innovation, that really create a humongous opportunity in the cycle of innovation in this. That's from containment, prevention, to therapeutics. And just to put it in very small 30 seconds thing so I can meet my 3 minutes, is one, shortage in PPEs create lots of opportunities for invention. Second, shortage of major equipment to treat on the end of that cycles, including ventilators, would create a lot of potential innovation. But the most important is twofold. One, information, particularly from a containment perspective, which means new platforms, IPs, apps, etc. But also the way we can distribute vaccine and tests if they happen, which means, okay, well, I mean, tests we have, but supply chain is going to be extremely important new way for any potential future pandemics, epidemics, or others, but also to cover a major hole that currently existing anyway in some of those countries, but that would speed up the effect and the work.
You know, you and I, Samir, have spent a lot of time talking about the need to see a lot more healthcare innovation and to see a lot more venture capital move towards those who are innovating in healthcare. Amongst your community, are you seeing any renewed interest within the investor community, specifically looking towards healthcare as a place to start increasing focus?
I think there's a delay in the private community to move forward. There's clear interest on the not-for-profit currently, whether the large foundations that we know of or even government. But from an investment sector, it's been delayed because everybody is guarded. Again, when you think about the economy, yes, you can do, but also the spending or the possibility of the presence of or available capital in some of those markets, or consumers being able to spend, is all a major flags that are currently waving in the face of a lot of people that has the potential of investing in emerging economies. So I believe it's going to happen and will happen sooner or later because it is a major area for innovation and major area for development. But now I think the community is pretty guarded.
Yeah, yeah. Rafik, I'd love to move to you. You've been on the front lines of response to the COVID crisis in London. And what have you and your colleagues learned about the virus? And more specifically, what have you learned about the importance of multi-sectoral partnerships and good public policy when it comes to handling global pandemics like this and flattening the curve? And then I have a few other follow-up questions after that, but I'd love for you to start with that. Rafik, you're on mute.
Sorry about that. I'm very sorry about that. So I was just saying that it's been a bit of a roller coaster journey for us as clinicians with the COVID-19 response, and it's put a lot of pressure on us as individuals and on the systems, and tested really the limits of our resilience. The first thing I learned about COVID is it's not the flu. I think in the medical sphere, many people initially thought before we started dealing with it that this was just going to be a bad version of influenza, which is something that we deal with seasonally every year. But it's not that at all. Whereas there's a big spectrum in terms of the severity, in the more severe cases, this just has an aggression that we're not familiar with in cases of flu. I remember talking to a colleague of mine in Italy before it started to hit us. And he said to me that when it hit us, it would be the most violent thing you've ever seen. And you see that on the front line sometimes in dealing with patients. The next thing I think that's key with COVID is prosperity doesn't make you immune. So the UK is a well-resourced health system. We're very lucky in many ways, but we were looking at needing, in sort of best case scenarios, 4 times the intensive care capacity that the system had, and in the worst case scenario, up to 10 times. There's no system that can flex in that way quickly, and so it's just not something that's possible. In terms of learning about multi-sectoral partnerships, this is a complex response that's multi-layered, because this isn't just a health issue. There's a medical side, yes, of course, but there are massive social and economic implications to it. And you just can't deal with it effectively unless you have some sort of multi-sectoral response and effective partnerships. So on one level, you have sort of sound public policy. You can't lock down people, for example, if you don't have a policy-making decision at that kind of level. You need effective communication strategies, which have been of variable quality, I think, in different countries, and sound strategic and logistical decision-making. In London, we have a very effective communication between geographical sectors, and this allowed for centralization of the information. So we all, if you like, had the same version of the truth. But in each sector, geographical sector in London, we had the flexibility to mount tailored response because our needs for our local populations are different, and we're resourced slightly differently. And you also have the role of general practice, the community, care homes, all of these things come together. And you need to be able to mount a coordinated response between all of them and do it at scale as the virus moves or the epidemic moves from one region to the next and hits people to different levels. So the multi-sectoral response is key to that.
So this has been weeks for you and your team working with critical care patients who have the virus. What are the kinds of innovations you wish you would have had that would have made this all easier?
I honestly don't think that anything would have made this easy. Easy is not a word that I would associate with it. I think there's some things that could have made it more manageable. I mean, I guess my top two innovations that I would have loved to see is, and I think we're all waiting, is number one, a vaccine. Number two, very quick turnaround point of care testing, because a lot of the time we see patients who we're not 100% sure whether they do or don't have COVID, and the turnaround isn't as quick as it could be. But other things are simpler. I mean, I think we just need a little bit more resilience in the system. We need a little bit more capacity with things like Professor Khleif was mentioning, ventilation, other things like that. And the key thing for me is the dissemination of knowledge, because you just need people to learn from each other really quickly in this kind of situation. How we're treating the COVID patient today is different from how we were doing it a few weeks ago, because our knowledge is evolving. So for me, the key thing is about making sure that we share that information quickly so that the next people dealing with this have that information and build on.
Yeah, thank you, Rafik. Gladys, you and many public health experts and climate scientists have predicted that climate change will increase the likelihood and severity of future disease outbreaks. So I feel like in a way that through your work, you may have been predicting something like this could actually happen. But as an epidemiologist and a healthcare worker, what kind of multi-sectoral policies do you think would have been able to promote the well-being of ecosystems and local populations better if we had been listening to people like you earlier? Did she drop off the call, Julia?
She did. I think she didn't like the question.
Yeah, oh, I could see that.
She just like dropped off right away. They hit mute and she's back. You're back, Gladys.
Gladys, you're back. Gladys, did you not like my question?
Yes, I'm back. Sorry, I don't know why my internet's so, yes, I've got the question. Okay.
Yeah, let me.
It's stable today, but anyway.
Yeah, I think Gladys, I think your connection is.
Yeah, I think we lost. Oh.
Not holding up the connection.
Okay, well, maybe.
Gladys, we can't hear you. I'm so sorry.
Can you hear me
now? We can hear you, but it's cutting up.
Okay. Even now?
Yeah, we can hear you now. Please go ahead.
Okay, I'll speak as quickly as I can. Yes, I would say that climate change has been whether it's malaria, and it mainly affects the vectors, such as the mosquitoes. There's increased number of mosquitoes if it's the case of malaria. And in case of things like anthrax, there's more bacteria in the environment, which enables the spores to. In case of COVID, as long.
Yeah, Gladys, you're still
keeps changing. We're likely, and I think one thing that we have to think about going forward. Can you hear me now?
No, it's not. It's really cutting up. But I think what you could do is if you could turn your video off and try.
Maybe I can. Yes. I'll stop my video. Is that?
No, I'm afraid not. But if you type out your answer to myself or Julia, we'd be happy to read it out. Is that okay?
Okay.
Okay. Sorry, Gladys. I know.
I'll do that then.
That's okay. I know internet connectivity is tough. But Teddy, let's move on to you. You're based in Ghana. Gladys is also in Africa, but just to give a little bit of an African perspective, I don't know if you were able to read the blog, but Ifosa Ajomo, who is the co-author of Prosperity Paradox and a native of Nigeria, recently wrote an article saying that Africa really doesn't need any more ventilators, but rather what Africa needs is to build the infrastructure required to build its own ventilators and to create a system that is not dependent on aid. So my question to you, from everything that you're seeing based out of Ghana and seeing what's happening on the continent, which so far seems to be holding off okay, is the coronavirus an opportunity for Africa, or are people still seeing it as a curse?
Well, you know, this pandemic, it has been a reset on multiple fronts. I think ultimately it's brought the focus on healthcare and research more sharply than before. As we can see from different countries, it's had different influences. But I think what's going to come out in the long run is that the most resilient societies are those that, you know, have the well-being of the vulnerable embedded in their being. I think that the societies that have been providing for their citizens from long ago have been causing some kind of, you know, social distancing, because there's a lack of interdependence on each other for basic things. Whereas in Africa, the status quo has been that there's a social interdependence that is needed for survival. And this is what has made it difficult to do some of the things that the West is doing in controlling this disease. I think that what the pandemic has forced us to accept is the level of underdevelopment that the healthcare and research space has had. And I think it's also obvious to me that there's a culture of leadership that sort of lifts leaders away from this, you know, basic social interdependence that we have, that sort of because of the needs that we have. And it sort of made leaders a bit blind to how badly, you know, healthcare has been over the years. So I think now COVID closed the door and nobody could get out. And we're forced as a society to look at healthcare as it is now and think about how to deal with it. I think the double blessing is that we have been sort of paced behind the rest of the developed world, and we can see the havoc that is wreaking on the developed world, and we have the opportunity to sort of prepare. I think whatever it is, whether we're going to be hit by the storm of COVID or not, this lag has given us the chance to prepare for the worst. And if the worst doesn't come, then all the better. Because the truth is that even if the worst does not come, we're left with our typical, you know, killers of road traffic accidents and other infectious diseases. And I mean, in Ghana, at this time when COVID has ended up with a mortality of about 18, we've lost about 45 people to cerebrospinal meningitis, which happens to be an epidemic which takes place around this time every year. And so ultimately, I think acquiring the capacity to manufacture ventilators would be a good thing. But the truth is the ecosystem that would have consumed the product and, you know, upscaled it to reach out with critical care on as large a basis as we've seen in other places just does not exist. So even if we could manufacture the ventilators, we would have to, in addition to that, acquire the ability to sort of incubate and nurture an ecosystem which will use the ventilators and use the infrastructure that comes with it. And that ecosystem does not exist. It exists in part, and our capacity on the human resource exists in part, but it must be a full package. And I think the opportunity that the pandemic has given us is to see how small the world has become and I think the shining star in this dark period has been technology. How it's managed to keep us all together, keep us talking together, give us the access to information that Dr. Rafik was talking about, and also the fact that things like telemedicine will no longer be the fringe. You know, it would come center stage because the technological infrastructure exists for it. And so at this time, we have the capacity not just to invent the wheel, we can print it, you know. We have the capacity, we have the technology to learn from what has been done and do something better.
Well, that's the hope. Before moving on to Deb, there's a very interesting question that has been posed from somebody from the audience. He says, for all the experts, and I think this specifically to the physicians, but everyone feel free to jump in. His question is about the emotional strain on healthcare personnel. Post this emergency, how does the system rebuild the emotional strength of the people who have been in the front lines? Rafi, I imagine you've been giving this tons of thought.
Yeah, we've had to. It's, I think in short, I'd say the emotional strain is massive. I mean, I've seen colleagues in tears just because of the physical and emotional strain of working this. It's difficult to imagine wearing full PPE and spending hours and hours in small confined spaces with very, very sick people. So that's part of it. But also what people need to realize is the environment is very different from what we would normally consider intensive care and hospital environments. I mean, remember, people don't know what it's like in other countries, but certainly in the UK, people aren't allowed to visit in hospital. You know, so there are really, really sick people who are there without family, who sometimes will pass away without family, and that's really, really stressful for staff. And we're certainly in London, what we have is we've put in systems of support with our psychologists. And actually, we've also asked the military to be involved because they have a lot of experience with that kind of stress and PTSD. And unfortunately, we expect that there's going to be quite a big aftermath after this is over.
Dina, I think there's something very important on this is not only an institution per institution. This has to be, even if you think of large countries like the US, has to be a national strategy that would be supported by resources, funding, and even research. Because there's a lot of this psychological and strain and stress that happen that might be very different from any post-traumatic distress that we know of, particularly of the nature of it, the amount of stress that's over it, and how it manifests itself. But especially that we're not talking about regular people, but also healthcare workers that are working within their own area and field. So it has to be embedded within national programs.
And if I may just add one small point to that is, I think we also need to recognize, because of the massive expansion of the capacity that was needed, lots of healthcare personnel, whether doctors, nurses, or otherwise, are having to work in other specialties. So, for example, intensive care has pulled in doctors from all sorts of specialties. So there's the added stress of working in an environment that is both stressful and unfamiliar.
Yeah. Well, with that, I'd love to move to Deb. Deb, you've spent the past several years researching and talking to consumers in America and really looking at healthcare through the lens of the actual user. What did you learn that is of relevance to where we are now in this pandemic?
Sure. You know, I think in the US, consumers are really just waking up relatively recently to out-of-pocket spending. So now Americans or American consumers of healthcare spend about 1/3 of all healthcare dollars out of pocket. That's about $1 trillion a year, but it's relatively newer for us, where people are sort of, it's dawning on us, oh, wait, we're paying for these services, or we're paying for this health insurance. And as a result, that leaves most Americans or folks using the American system, you know, unprepared to navigate on our own. We don't know how to we don't even realize we need to make those decisions for ourselves, let alone how should we do that, or how could we do that well. The consumers I interviewed or I met who wanted to do that or recognized their role as the potential for an active consumer were met with barriers and obstacles within the system. So the population, the mindset is not here in the US, and the system is certainly not built for consumer empowerment and navigation. And I think we see, and Dina, you and I have talked a lot about, really, I need to give you credit for this notion that never before has the individual's actions been so important or so obviously vital. So here we are with an unprepared population, you know, in a healthcare crisis that actually requires individual action and responsibility, and increasingly really self-care and navigation. Like, how do I know I should go or I shouldn't go to the doctor right now? You know, a lot of that's being left to the individual. What do I do if I need healthcare and I've just lost my job, like 33 million Americans? So the population here is much more vulnerable, I think, on these measures or in this way than we might realize. And I don't think that's setting us up particularly well among many other cultural factors that make the US quite a hot mess right now, if I may say that.
No, please do. We're all feeling the hot mess. I think it's a for the most part a global hot mess. I want to follow up very quickly, because you and I have spoken a lot about whether or not this pandemic might be an interesting moment to finally see a lot more innovation and creativity happen in the prevention space. And for such a long time, the whole focus has been on actual medical care. And all of a sudden, I feel that there's so many people I talk to who feel like they have a sense of agency now. You know, if they take care of themselves, if they work on making sure that they don't get sick, then they don't have to go into the system. So do you see this as an interesting moment where there may be a shift to where we're finally able to say, consumers, you actually have a big role to play in your health, and we can start innovating and giving you tools to actually do that?
I think the glass half full view.
Or are we not there yet? Are we?
Yeah, I think it's the perfect question. Of course, I think that you know, you and I, we don't lightly, you know, throw around the silver linings of this really, really dark and difficult situation. On the other hand, I think we know change is so difficult to manifest, and that change comes from necessity and urgency. And certainly right now, the US, those of us inside the US healthcare system have known all along it's quite messy and in fact fragile and disjointed in many ways, and dysfunctional in many ways. I think we now all know that, right? So the US vulnerabilities, the system vulnerabilities or weaknesses are laid bare. And I do think there's a lot of power and positive outcome of visibility. What do we do with that awareness? You know, I would really like to believe that policymakers and, you know, innovators, you know, take the mantle and run and improve. But I think it will come down to what do consumers do? What do voters do? What do individuals do? So I hope we take this moment to change the role of individuals for the good, and that, you know, individuals here recognize the power we have. But I think we may need to nudge towards that. I don't think it will magically happen.
Absolutely, but I'd love for the conversation to shift to the entrepreneurs. But Deb, you've been working with the Legatum Center and doing some research on really understanding what kind of innovations are actually happening in healthcare within emerging markets. What are you seeing there that is perhaps different when it comes to how emerging markets deal with health and also the pandemic?
So, staying on the theme of this, you know, this role of the individual, the entrepreneurs I've talked to, you know, in many emerging markets For better and worse, I'm talking to people in systems where the only healthcare most people can access is the care they can pay for themselves. And so entrepreneurs in other parts of the world understand from the get-go that they must serve consumers, and they must design their services and their value proposition for individuals. And if their solution doesn't work for the individual, it's not going to fly. There are many other factors, but that's at least a gating factor for entrepreneurs in emerging markets. I think there is something, there are a lot of negatives with that, but I think there are a lot of positives as well. So everyone knows the role and the importance of the consumer, and health solutions are designed for those end users natively, not sort of through intermediaries and corporate interests like we have in the US through employers and insurers. So I think that getting closer to the end user is a positive and really sort of a key feature of entrepreneurship around the world. I think in the pandemic, these entrepreneurs are, again, just quickly to the point of urgency, it's not like anyone thinks the system, in some of the less mature healthcare systems, no one's waiting for someone else to come in and solve our problems. So the entrepreneurs that I've talked to are just jumping right in and, plugging holes wherever they can. It is amazing and quite inspiring.
Could not agree more. So let's move to the entrepreneurs. So Amr, I'd love to transition to you, and I wanted to thank you for joining us. I know this is around the time that you break your fast, but thank you for sticking with us. You started a business that works on affordable health insurance, and just picking up on the thread that Deb was talking about. When you created this business in Egypt, you really had a hope to somehow be able to serve the most vulnerable and remote and those who fall out of the system and really don't have anyone to help them navigate a system that is very difficult to navigate even for the best of us. And what are your thoughts on what is happening right now with the pandemic, and what are your thoughts in specific about how healthcare insurance really needs to change to serve everyone and make sure that everyone gets the best care that they can, specifically under times of a crisis like this? Amr, we can't hear you. Are you on?
Hello?
Yes, we can hear you now.
So I don't think health insurance is going to be perceived again as it was before, because up till now, one of the major things that hasn't been addressed is cost. Who is going to be paying for all this in terms of whether medical treatment, which is being done, not just the indirect economical effect. So one thing is that one of the pandemics are an exclusion from any healthcare policy. Now, this I think is not going to be able to continue in the world. And we keep on forgetting that there's a lot of healthcare expenditure in the pandemic now, but the rest of the diseases are still out there. So all the chronic diseases, all the other illnesses, all the other problems are still out there. And I think there's going to be a backlog of patients who have had backaches and knee aches and who need knee replacements and who have a big backlog. And we have to start thinking of the idea of how do we manage that. And then at the same time, this is managing how we're not prepared, because we were not prepared for this. No one had, 6 months ago, I think no one would have even assumed this is going to be happening. But now we know that there's going to be a second and third wave, and with them, there's going to be other healthcare expenditures in more and more difficult times financially for everyone. It really has to be looked at from all parts. And I think I couldn't agree with Deb more about the idea that the navigation of the out-of-pocket expenditure and how complex is this is one of the major problems. It's not just about having health insurance, it's about having someone to tell you, because this is one of the diseases which has not made a difference between the West and Africa, between how rich you are or how much access you have. You can still get the disease, and you can still get have that effect. So it has to be a more broader view, and I think this is what's going to be starting to shift. You will not be able to solve all the problems, but you need to look at the second and third waves of the pandemic, and at the same time, what about all the other costs of healthcare which are out there now, and we either are not spending, and then we're going to be spending them in the next 3 to 6 months, and then moving forward, how does this impact the new healthcare systems and health insurance systems? So one of the major things the company immediately did was, because we're a very tech company and we build our own software, so we were able to work remotely completely. Now, this is very difficult in a company like Egypt. So this is one of the things. There will be a shift towards tech. The idea of who does, if you do not have health insurance at this difficult times, you need more and more information. So it's disseminating information, both digitally and non-digitally, because again, in a lot of parts of the world, we still have major problems with internet, we have infrastructure problems. So it has to be thought of technology which works and solutions which work. And then the other thing is that, and I like the word consumer empowerment, because we're going to face a lot of people who are losing their jobs or who are under severe financial pressure, and they have been spending on healthcare. So we've launched programs and initiatives to reach out to the organizations which they have that access to all of anyone who has lost a job, who has more difficult problems now, and to minimize this out of pocket, to make his loss less. Because I could not agree more that this is a very strenuous and emotional time for the entire world, not for just, of course, for doctors, it's tremendous, for all healthcare workers, for nurses, but for everyone in the world. So this being scared all the time and then worrying about you and your family. So we think that we need to reach out more to other organizations to make this transition easier. Because I think at the end, things are going to fall in the right places, and we will learn from this lesson, hopefully. But the distribution of more services, and not just regarding the pandemic. I know this is the main thing and main concern now, but there are so many other things, like Dr. Teddy was saying, so all the other diseases are still there, and all the other pandemics and epidemic problems are still there. And one thing which is reserves and fairness. I think this pandemic has taught us that fairness is going to be quite important. We will not be able to not look at everyone in society getting adequate healthcare. Not the best, I don't usually use the term best, but adequate healthcare. But we will no longer be able, if we leave out 10% in this virus, just 10%, and ignore these 10%, it will come back. So this is, I think, that consciousness of society and of individuals is extremely important. There is a cost, and we have to know about that. And then it's a matter of how much you disseminate and distribute. And then lastly, it's building up these reserves of human beings, of human capabilities. It's not just like in wars. This is a war against this virus. So you have to be able to, if this happens again, because we don't know how frequent this might happen and how hard this is.
Thank you, Amr. It's interesting that many of you have mentioned equity and fairness and how this virus doesn't discriminate, but yet our system actually doesn't really have equity and does in fact discriminate. So towards the end, I'd love to come back to this question of equality, but Javier, I really wanted to come to you. You're in Mexico, and you started a business to serve patients with diabetes. You have 16 clinics across Mexico now. You've achieved a scale in a very short period of time. I'd love to hear how you have perhaps pivoted to deal with COVID-19. And if you haven't, what have you guys done to protect your patients? Because diabetes patients are high risk. So what have you been doing in Mexico to serve your patients better, and also to use your business model to also support what is happening with the virus?
Well, thank you. So I think in terms of diabetes care, there's definitely going to be a before and after. And it has really changed the environment and what we're seeing around diabetes care and hypertension care, mainly because at least in Mexico, 80% of the deaths from coronavirus are related to the lack of control for hypertension and diabetes. So what have we done so far? So the first one, it's a huge awareness. So our call center calls increased about 700% as people were really worried about what happened if I don't have the right diabetes control, or how am I doing? So we have to adjust all of our operations, of course, first for the safety of the patients and the staff to be able to operate under these new conditions. And at the same time, we have to very rapidly implement phone and remote consultations to be able to reach out to patients that were staying at home and were concerned about going out, that it was part. At the same time, corporations were asked in Mexico to everyone with diabetes and hypertension should stay at home. So how we serve several transportation companies and be able to also manage their employees that were staying at home. And why I think it's going to be before and after. So one is the awareness. And we should not forget, just as Samir was saying, diabetes kills 150,000 people in Mexico every year. So it's almost 10 times more than what we're expecting from coronavirus. Two, I think the government will have very low resources after the pandemic to face other conditions like diabetes and hypertension. And just as an example, I mean, there have been thousands of ventilators acquired by the government. Well, the cost of one ventilator is the cost of one clinic for diabetes care. And the impact in one clinic on the long term and for diabetes. So we definitely, government's gonna have a challenge of what's gonna be after for all the rest of the diseases. But the most, I think the most interesting one is digital health has been a challenge for healthcare services, especially because of the cost of acquisition. It was extremely high before. Just making someone 50 plus years old log into the internet, get a virtual consultation, and it was just almost impossible. And that's why it was a challenge. Not too much because it was easy, but it was the cost of acquisition. With the lockdown, that cost of acquisition has come down to zero. Everyone now is logging in. Even my mom now knows how to use Zoom and get into a virtual conference or a panel like we're doing right now.
I know my mom is watching now too. It's
probably yes. And so the question to me is, what's going to be the cost of acquisition after COVID-19? Probably no zero, because people will start going out, but it's not going to be the one that used to be before. So that brings an enormous opportunity for us in which type of services are going to be sustainable and which type of services can be switched to digital. Just as we operate in Mexico, and as you were mentioning employment, we're seeing now people even from the US reaching out to us and see, I'm unemployed, is there anything that can be done? Other states in Mexico. So for us, it's been also how we're going to adapt to this new reality, not only when we have physical clinics, but also how we can serve remote patients in other regions. And so definitely it's just, I think it's going to be very interesting for new opportunities for innovation. There's going to be systemic change, absolutely, because the main factors are changing. I think governments are going to need help. So before, at least in Mexico, was private, public, a little bit separated. I think we're going to have to work together to be able to solve these challenges that we have ahead.
Yeah, I could not agree more. I'm going to come back to you again, Javier, but before I do that, Anatole, you're currently a fellow with us, and you developed a business that works as a contact tracing solution, and you've recently, for STIs, and you've recently pivoted to do contact tracing for COVID. Can you tell us a little bit more about your experience as an entrepreneur in this space, and how easy or difficult has it been for you to pivot your business to fully focus on COVID-19?
Well, Dina, yeah, well, I've been working in contact tracing for 4 years. It's it's a difficult thing to do, especially when you have a high volume of contacts to inform, which you do with an infectious virus such as COVID-19. But in sexual health, we've been doing it for 4 years, using SMS and email to inform contacts. It's an anonymous platform, and make sure we can link those individuals into care. And it's not just letting people know, it's how do you help them navigate the healthcare system to get access to testing or care if they're unwell. But then how do you actually measure outcomes? And what's interesting since COVID-19 is everyone's talking about contact tracing. And there's a lot of approaches. There is a sort of brute forcing where you just employ more staff to do more of the same, or there is a lot of people looking at different apps that use Bluetooth beacons as phones to talk to each other, or GPS. But a lot of those haven't really been properly evaluated. They just hope, people are just hoping that they will work. But what's interesting for me when I look at this space is that actually getting good rigorous outcome metrics has been very hard in contact tracing. It's very manually intensive. So, a lot of countries have, started employing many people and want to really use the old tried and tested methods, even though a lot of their outcomes are really poor. So as developing something new and helping and trying to speak to people in the front line to see if we can support them with the software is actually a big challenge, because the tendency is, oh well, we'll use a new shiny tool that hasn't been evaluated, and we'll use the old methods which we know and trust. And actually getting someone to then think about using a different approach that's being proven to work in another area is a challenge. But I'm starting to have some interesting conversations with people, and the good thing about digital tools for me is that you can actually measure real-time impact, and you can actually show how effective methods are. So I'm looking forward to seeing how contact tracing is going to be developed over the coming years, and in terms of how we evaluate it and how we look at its use in the future, because obviously this virus thankfully isn't that lethal. It's obviously travels fast, but relatively speaking, it's not Ebola, which of course is the sort of the classic viral infection that people rightly fear. But this one is thankfully less lethal. Consequently, it just allows us to have a wake-up call and really think about what would happen if we had SARS traveling at this speed, the original SARS, or Ebola traveling at this speed. And it raises a lot of awareness that other people have mentioned, that there are people in society who are vulnerable because of the way society is structured. If they are ill, they're not managed appropriately for their diabetes or their hypertension. They don't have those things under control. And then when something like this comes along, it does really lay bare what has been, a poorer access to high quality services for large fractions of the population.
Yeah, Anatole, very quickly, Dr. Amr Tayeb has a follow-up question for you. He wanted to ask you about the privacy issues in tracing, wait, Amr, you're there. Why don't you ask your question?
So one of the things which comes to mind immediately is privacy in healthcare. Privacy in healthcare was one of the major problems with telehealth, with health informatics, with everything. So how are we going to start looking at privacy issues in contact tracing? Because in theory, it is something which is going to be quite complicated and can be used for other things apart from fighting the virus, fighting in general healthcare. And I could not agree with Javier more in that the acquisition of customers and the penetration of how patients are going to use technology is going to grow intensely. But how do we tackle the privacy issue? Because we know it's very important, very useful. At the same time, we know that there were so many restrictions before in compliance to it. And it's one of the major things because it can be used for other stuff also.
Yeah, well, it's a very good point. So contact tracing in sexual health is one of the most stigmatized areas of healthcare. If you think about HIV, for example, and people are reluctant to inform contacts because they're worried about being identified. So we built the platform anonymously. And then what we did in our system which is GDPR compliant, is that we use email addresses and mobile phone numbers to tell contacts of their risk and alert them to where a local testing service is, and then we have a booking module that links them to care. But we don't actually, all the private information, the emails and the mobile numbers, are encrypted once they go in the system, and then we delete them once we've delivered the service. And then we use unique codes to track how everything is working and that we can prove outcomes. The ACLU, the American Civil Liberties Union, had just published a white paper in April about technology-assisted contact tracing. And they made some very, very strong points around, what is the role of technology and to support this. In the building the SXT platform, we took all of those considerations to mind, that we have to support current healthcare infrastructure. We have to make sure that the whole network works together. We have to make sure that, that we're not abusing this information, which is highly sensitive. So we've taken the approach that we strip it all out and we just make sure that we can have as little big brother as possible to deliver a high quality service. But I think a lot of people are seeing that, the countries that have done so well to contain this, they've done it through mandation of putting apps on phones, turning on geolocation, basically, enforcing, home imprisonment for people to stop the spread, and that's very effective. But actually, there's a lot of countries where that sort of level of control wouldn't be possible. And I think people are rightly need to debate this and have good conversations around where are the limits of public health enforcement, because it becomes challenging when you have these databases that could in theory be opened up by other actors and used for other means.
Yeah. Thank you, Anatole. I want to transition and bring in some questions from the panelists, but before I do that, I think, all of you, you're an amazing group of people, and I really brought together entrepreneurs that I really respect, and the work that you're doing is amazing, and what I would consider truly systemic in terms of the ability to transform. But I'd love to hear from the physicians in the group. Now that you've heard from some of the entrepreneurs and heard about their innovations and what they're doing on the ground, I've often felt that there's a little bit of a disconnect between people who are out there serving patients in the medical field and what innovators are doing to really find ways to make sure that healthcare is available to all. How do you all, as entrepreneurs and also the doctors in the group, do you think that now is a great opportunity, or do you think that physicians will somehow migrate and become entrepreneurs or speak more frequently to those who are coming up with innovative solutions to some of the gaps in the system? And maybe to the entrepreneurs, and I'm looking at Javier, I feel like you want to say something, but do you think that this is also a great opportunity to see deeper partnerships emerge with the existing systems to create something that is even better? Go ahead, Javier.
Well, if the physicians wants to go first.
I'm sure they'll jump in.
Okay, well, definitely I think this type of crisis bring people together. So even worldwide, we typically work in silos by country, and now it seems that the whole world is working together through finding solutions. And so I think it's the same. I mean, innovation, if we just, I've been years in innovation, more than 20 years working in innovation. And as human beings, we want to be stable. I mean, it's just by the way we think. We don't like innovation. We like routines. It's just like we feel comfortable. And it makes us happy, because otherwise every day we'll be finding new ways to do things, and our life will be miserable. So innovation, that's why innovation is a process where you find a solution, you push the boundaries. A crisis makes things to go faster. So I think in our case with our physicians, we have more than 50 physicians, and then nutritionist, psychologist. I think it just brought us together and see how we can very quickly implement, for example, remote consultations. And if we think about the physician before this this pandemic, they were reluctant to log into a computer and see a patient on the screen. But now they are worried about getting the virus. So when we brought the remote consultations, for them, it was a great tool because it's a way to protect me and protect the patient. So a few months ago, a threat now is the best tool to be protected against the virus. So I think this is why this always we say crisis, and it's this process how you have this sense of urgency and just a matter to work together. So I think that I'm very optimistic of what's going to come afterwards, and definitely brought us more together, administrators and physicians, and
Yeah.
I think we have to take advantage of this time.
Yeah, Rafik.
So I want to echo some of what Javier said. The thing with what's happening now is it's defined the need very, very clearly and acutely. And I think essentially when you talk about innovation, and to my mind, entrepreneurship is about how you harness the value in that innovation. But the innovation is very much about defining what you need and then trying to find a solution for that problem. I mean, in the UK, we have lay people who are 3D printing face visors because there's a shortage. You have, similar to what Javier's experience was, I was responsible for a project in our hospital, one of the big hospitals in London, where our aim was to try and to go to virtual clinics for 15% of our patients over the coming year. We did it pretty much overnight when COVID hit to 100%. And so I think when you're put in a situation where you're very clear on where your problem is and what you need, then you have an environment where people who are on the front lines, like the physicians, other healthcare professionals, and people around them, are very much in a place where they can cooperate with people who are entrepreneurs, forward thinking, and together they can define what the solution looks like, or what a solution looks like. Because I think one of the things we've learned through this is actually you can have multiple solutions to the same problem, and they may be context specific and useful in different ways.
Yeah, I think our hope is that we don't need to wait for a crisis to see these kinds of partnerships forged, but rather to come up with better ways to provide healthcare.
Yeah, I think the last thing I'd say on that is one of the things with COVID-19 is how we harness, so this sense of crisis, how we harness some of the good things about how we're doing things now because we're so pressured, and make sure that they last.
Yeah. Yeah.
So
Samir, you're off mute. Did you want to add something?
On that point?
Yeah, the other issue that
sorry, Amr, I'll come back to you.
Think of is
Go ahead.
Probably there are three layers of this. One is, look, physicians have been always at the forefront of innovation. But the problem with the innovation that physicians have been at the forefront of is at the end stage of the innovation. Now, because of the practice, it is shifting more toward the early end of innovation, or the early innovation, particularly in practice implementation, which is really a major part of this. That's one, like telemedicine. But I mean, we're discovering that 40% of our clinic visits are unnecessary now, because we can do it on, and we've been doing it for the past 2 months on telehealth. This is going to change forever. Hospitals and physicians are not going to be doing those visits that now we know clearly they come to the forefront. It was going to change anyway within 10 years. That brought it all to the forefront. So that's one layer. The second layer is regarding innovation. I mean, the issues that we talked about, which is the developing and emerging market, particularly on tracing and containment, discovery, tracing and containment, is not an emerging economy problem. After all, the virus started in China, and now the most dead people are in the US. So it is very important that this is going to be a major emphasis on innovation and discovery of how we contain things, discover them and contain them at their source, at ground zero. That's going to be extremely important, and probably one of the major emphases that's going to happen in the next few granting cycles. The third element or the third layer is policy. Policy has to change. When we talk about things that the COVID-19 brought to the surface in healthcare, there are lots of things are changing, including medicine. When we talk about HIPAA doesn't comply with majority of what we do on telemedicine and healthcare. So there are lots of issues in innovation has to be in regulatory, legislative, and policy that has to become forefront.
Yeah, and Dina, just to add the fact that, you know, in the limited resource setting, that transition from physician to entrepreneurship has already been happening because, again, it's sort of facilitated by the lack of central capacity to provide for health. And so that transition has already been happening. And I think what COVID is going to do and what this situation is going to create those partnerships between those entrepreneurs who already exist with the new technologies that we can use in this new phase. And also to build partnerships with the environments where, you know, big practice has been going on for ages. I think realizing how small this globe has become is going to sort of catapult a lot of the, you know, medical entrepreneurship in the emerging markets to greater heights than before. And I think that this is going to also open the eyes of the entrepreneurs in the developed world to what is possible in the developing markets. So I think it's only good things that are going to happen in terms of health innovation in the developing environment.
That's our hope. So another question from the audience is, one thing that emerging markets need to grapple with is whether to implement the same strategies that have been used in high-income countries. 3 factors seem quite important. 1, much younger demographic in Africa, 93% under the age of 55. Teddy, you and I have talked about this before, which means fewer severe cases, right? Number 2, health system capacity is much lower, so flattening the curve, you know, is not as helpful. 3, the economic impact of social distancing and lockdowns leads to nearly immediate death due to hunger and starvation. I'm curious about the panelists' views on taking a radically different approach to COVID in developing countries that match these criteria as compared to what has been done in the West. Any comments from the group?
Yes,
I mean, okay, yes, please go ahead.
I'm sorry, I feel very strongly about that. Not one.
Go ahead, Amr, and then we'll switch to Teddy.
Sorry. It's a word mindset. So I'm a big fan of the word mindset. So perspective. This pandemic is going to change our perspectives and our mindsets. And I'll be very brief. So one, yes, entrepreneurs need to start addressing real needed problems now, not just thinking of I'm going to be the Uber of this. They have to start thinking of real problems, practical problems, and they have to think in their settings. So I cannot take the US, for example, and then apply the same things in Africa or in Egypt because we have other problems. There are certain limitations which we need to address. It's very, very culture and area specific. The other thing is there are limitations to technology. There's a very good question about, I'm a gynecologist from Ghana and who sees pregnant women treat infertilities. So how do I manage patients remotely? So we're going to be thinking in a different way, addressing different problems. And I think there's going to be not just doctors or entrepreneurs, but other people who are of concern, who have been at home for a very long time, or who have not been able to stay at home, looking at these problems from a different context. That will make society have a completely new mindset of entrepreneurs and of how you look at healthcare. And the most importantly, I think this is where money is going to start pouring in, because generally VCs, PEs did not looked only at classic investments in pharma or in healthcare providers, but they will start looking at supporting and financing these other innovative solutions, and because their impact and their need will make us prepared for something else like this.
Teddy?
Yes, I think what I'll add is I think ultimately some of the things that have been working in the developed world will definitely not work here. I mean, things like social distancing are impractical in some environments that we have. But the thing that I'll take away I mean, and then a lockdown, for example, is not very practical in our environment. And even though it's been done, I think the capacity of the lockdown to limit the disease has been shown. It's not really done as much as we thought it would have done. But the thing is, what we can take away from the developed world as far as the approach is concerned is the testing. Because I think our key weapon, our key resource is information in this pandemic. And the more testing we can do and the more characterization we can make of people who have it, the more we have. And I think that ultimately, because our population will be younger and will get less disease, it might be where we start, getting the capacity to test for vaccines. It might be where we develop the capacity to follow people and look at the natural history and harness information that will be useful for the world at large. So I'd say that a lot of the things that have been done in the first world may not be applicable in terms of containment, in terms of control of the disease. But I think this, in the emerging world, information and looking at the disease in different ways and following it will be really crucial for the world at large.
Do you mind if I jump in there,
Oh,
Dina?
please jump in.
I was going to say what the developing world could learn from Europe is maybe looking at Sweden. Their approach is replicable. They've isolated people who are at risk, and the rest of the population are, they're going about sort of normal existence. The reality is, and this is being modeled by people at Harvard School of Public Health, that if we do a lockdown, we still have a whole swathe of the population who are naive and at risk of catching the virus in a later wave. So we do need to make sure that the vaccine isn't going to come anytime soon. And there's a lot of people who are going to die of malnutrition or starvation if they don't get access to food. There's already reports all over the world that supply chains have been affected by this. So I think we need to get the basics right and think about what are the ways to protect the most vulnerable, and then and Sweden's got some good examples of leadership on that.
Yeah, thanks, Anatole. Does somebody want to add something?
Yes. Can you hear me clearly?
Gladys,
now?
We can hear you. Please.
Yeah, I'm using
we'll
my
let Gladys
phone now.
speak, and then we'll go back to you.
I just wanted to respond on the issue of lockdown. Here in Uganda, we've been in lockdown since 26th of March, and we only have 100 cases. In Tanzania, they've not had the lockdown, and they have close to 1,000 cases. So I think lockdown can work in Africa. They've been really strict with social distance. Well, lockdown mainly has helped with social distancing. And as far as feeding of the poor, the people who don't have access to food, people are finding different ways to feed them. The government's giving them food. But us who live around conservation areas, we're very concerned, obviously, about poaching, because tourism is now down to zero. And we're looking at ways that we can provide, income through maybe ready-to-made food or ready-to-made crops, or even supporting industries such as coffee, where it can go through cargo, which is something that our NGO, Conservation Through Public Health, is doing. So I really think lockdown is working in Africa. I'm just looking at two examples, two neighboring countries. In fact, the only reason we're having a few rising cases is truck drivers coming from Tanzania and countries where they don't have lockdown or strict lockdown. Thanks.
Thank you, Gladys. Samir?
Yeah, look, the thing is not black and white. I don't think that we can make a statement that whether measures in the West work in the measure in the East or underdeveloped world or emerging economies. The bottom line, it's not too fast. There are going to be lots of writing about this period that we're going to be learning from a lot. And I totally agree with Gladys. In certain countries, like Jordan is a case in point. Jordan locked down complete. The past 7 weeks, they have only 500 cases, while neighboring countries has 10,000 cases. So the issue is, though, it's not purely lockdown and what, it's the system, is how you develop a system from A to Z to be able to assure, one, if the lockdown is going to be happening, how you can address all the rest of the measures from a socioeconomic perspective. And I think there are lots of things are going to be coming out and lots of reports are going to be coming out, and we're going to be learning from what best to be done coming in the future. So I would not say we should make any conclusion at this stage, say this works or this doesn't work.
Right. Well, I know that we're out of time, and I think we do have to wrap up, and I think this will be the first of many discussions as we all try to navigate our way through this crisis. But I'd love to hear from each of you. I think everybody here is in full realization that there are many opportunities that have been revealed to us over the past couple of months about how we can improve the delivery of healthcare, but also how we can improve the overall health and well-being of citizens around the world. So it would be great if we could conclude maybe on a more forward-looking note, and I'd love for each of you to share with the audience what your hopes are for healthcare innovation moving forward. And if you were to, fast forward a year from now, what is the one thing that you would like to see truly transformed within the healthcare system or in other systems that are impacting healthcare? I'm just going to call on each of you based according to what the order of the boxes on my screen. So Teddy, you're up first.
Well, I think I'm just looking into the future and just looking at the role that technology is going to play. I think that ultimately technology has been fast-tracked as far as contributing to health is concerned during this time. And I think looking into the future, what I'm going to really be encouraged about is just a change in this thing about the developing world and how advanced the medicine should be. I think the story has always been that primary health care should be, pushed in the developing world and not critical care. I think this is going to change the whole paradigm. And I look at different ways in financing, different ways in pushing technology. I'm looking at, healthcare really blooming in the emerging markets.
Thanks, Teddy. Anatole? Anatole, we can't hear you.
Can you hear me now?
Yes.
Yes.
Yeah, thank you. I think there's going to be a real focus going forward on social determinants of health. I think what's happening in the United States is very telling, and we've also seen data in the UK where particular groups who are have more of certain disease like diabetes in the Indian community in the UK or hypertension in the Black African community, how they make those individuals more vulnerable, and they've adjusted for concentrations of housing and things like that. So I think the understanding of at-risk groups and targeting specific interventions to those individuals to help them be healthier in the future, I think is going to be a big lesson from this. In terms of technology, there's going to be this revolution in telemedicine, which I'm very excited about. I'm working with 2 California physicians about moving a fraction of the emergency department into telemedicine space, because 80% of the people who turn up with COVID, emergency department gets sent home. So I think there's lots of examples where that could be managed at home.
Thanks, Anatole. Samir?
I would say data. This is going to happen. This is probably the most important thing that's going to come out of this, is how are we able to develop platforms and collect, integrate, aggregate, analyze, and get output in the easiest and most efficient and fastest perspective. Because what's happening in the past 2 months, it's just mind-boggling. First of all, the disease is not changing, but the output of the disease is changing per minute. I mean, we see patients' presentation completely different from day to day. The issue is, if you look at the literature, there's 9,000 papers published on COVID only in the past 8 weeks. So the point is, how do we learn immediate, real time, and make output? And that's going to be data platforms.
I completely agree. Amr?
So I think what I'd hope for is perspectives from everyone, from government policymakers, from doctors, from patients, from all society, from investors, on how they are approaching the dynamic of healthcare, and realizing how important it is, how much it becomes really important that you cannot weigh a price on human life or on human suffering. So this perspective, I think, if we manage, if everyone comes together, this is what I really hope for, from all stakeholders, and nothing in specific, but just it's how we're going to start thinking about this.
Yeah, co-creation and collaboration, I think, will be critical moving forward. Gladys, are you able to, I hope you can share your thoughts.
Yes. Yeah, hopefully I'll be able to share my thoughts on the phone. I think that going forward, we're going to have to start really considering One Health approaches to healthcare. It's been very much human focused and curative focused, but we're going to have to think more about preventive, working more closely with epidemiologists. It's widely believed that COVID came from the Wuhan wet market in China, where wild animals like bats or pangolins or civets are put in a very small area. They get stressed, the virus spreads quickly in tiny cages. It got to people. It spread very quickly in people. It can spread back to wildlife like gorillas and chimps that are very important for tourism. And so there's going to be much more focus of doctors, work more, conservationists, environmentalists, the issues of climate change, deforestation, which brings people in a way that they shouldn't be. So I think there's going to be much more of an interdisciplinary way if we're going to be able to tackle and be ahead of a lot of these pandemics, which can basically keep occurring if we don't change human behavior. Eating meat from unknown sources, it gets into the public and just keeps spreading. So I think there's going to be more of that. Our NGO, the conservation NGO, and through this we've been able to take, and now we're working on the COVID issue altogether. And I think there should be much more approach. Health people, human health people have to start.
Okay, thank you, Gladys. It's really hard to hear. Deb?
Sure. I think in the US, the reality is our system was not working for millions and millions of people. And the crisis gives us a shock, a rude, horrible shock that I hope we will use to, really break the systems and incentives and business models that were not working and come out the other side with more equitable access to care and coverage, and to sort of provide a stronger layer of protection for, frankly, everyone, including vulnerable people, but economic protection when it comes to healthcare.
Yeah. Thank you, Deb. Javier?
Well, my hope is that just as we're seeing billions of dollars invested in this pandemic, and we can see the same investments for preventive care, for chronic care, and just as the Mexican government urgently acquired thousands of ventilators and 3,000, 4,000, they can say we need to build 4,000 clinics for prevention and for chronic care. Just with the same sense of urgency, we were willing to stop businesses, and we're willing to stop businesses to contain diabetes and hypertension, and just the same urgency and the same investment. That's my hope.
Thank you, Javier. And last but certainly not least, Rafik.
Yeah, the innovations that I expect to see and hope to see are all related to how we structure and deliver healthcare. So there are structural changes and information flows and information sharing. And I think the technology, etc., all of that will support that. For me, it's going to be about the how we deliver things rather than the what platforms or solutions we actually use.
Thank you, Rafik, and thank all of you for joining us today. There are some comments from the panelists asking for more and more follow-up discussions. So I hope that you'll all consider joining us again for subsequent webinars on this topic. And I just wanted to thank all of you for all the amazing work that you're doing. And I've known Amr and Rafik for over 20 years, and I could not be more proud to call you both friends. What you're doing is amazing, and all of you. And Javier, I think what you're doing in Mexico is just, it's absolutely incredible. And Teddy, I read your posts religiously about Ghana. And you know, Samir, I'm your biggest fan. So I'm hoping you'll come up with some good research that will help us tackle this virus that has hit us so aggressively. So thank you all again, and thank you to the audience for joining us. And we will definitely be doing more follow-ups on this topic.
Thank you, Dina.
Thank you.
Thank
Thanks
you
for organizing.